Welcome, everybody, to the third episode of Let's Talk About Access. I'm very happy to have with me today Kate Steiner, an interventional radiologist from UK. She works at the Royal Sussex County Hospital in the beautiful Brighton. Kate, welcome. How are you? How is Brighton?
Particularly beautiful at the moment because we are in the middle of a heat wave in the UK. Probably be quite cool for you, Alex.
So, Kate, how you being a radiologist, we know that you accessing, the IR suite and doing everything with fluoroscopy. It's not the most common to use ultrasound so much for lesion characterization, etc. I think most of our colleagues are radiologists. They would use perhaps ultrasound for just puncturing, but not necessarily more. How come you developed this interest in using ultrasound even for studying the lesions?
Thanks, Alex. So true. When I started my first consultant job, it involved vascular ultrasound sessions. And I kind of changed those sessions over time into setting it up more like a clinic setting. So seeing patients who are referred for access dysfunction, then performing the treatment, and then most importantly as well, is seeing the patients for follow-up. And then you kind of complete that whole patient experience and patient journey. So what I found was when I was doing ultrasound, being a sort of curious person, I noticed that not all the lesions look the same, and that I could see lesions where there was predominantly intimal hyperplasia, and those lesions where there was no intimal hyperplasia. I noticed that they seemed to fall roughly into sort of several groups. One where there's no intimal hyperplasia, one where it's almost completely intimal hyperplasia, and those where the lumens narrowed and there's a degree of intimal hyperplasia. And when I started first as a consultant, give away my age, it was a while ago in 2012. And so then we'd really start using DCBs in the arterial lesions. And we weren't really yet using them in dialysis access. It wasn't yet established. And that's where my curiosity came. Like these lesions that I'm seeing coming back with the intimal hyperplasia, those should be the lesions that respond to DCBs. And I did a little bit of research, finding out that there were a few papers already published where people had looked at different types of lesions and how they'd respond to plain balloon angioplasty and bare metal stent insertion, but I didn't see anything as yet really looking at intimal hyperplasia and drug therapies. I carried on my work. Now I've moved hospitals in Brighton, and we've set up recently a joint renal vascular access clinic also involving nephrology as well. And I think that's kind of the way forward. It's that joint working involving IR as well, where we all bring to the table a different skill set and a different option or a different way of looking at perhaps some of the access problems. And when you work like that in MDT, it's when two things happen. Well, one, I think you get good care for the patient because they've got all the options, but also you start to push the boundaries a little bit as a group and think jointly out of the box.
So, how easy is it to differentiate when you're uh, observing the lesion under ultrasound, whether it is intimal hyperplasia or something else? What are the signs? Can you describe a bit the lesions? How do you
Yeah.
know what is what?
Yeah, I think it's really easy, and I've taught over the years registrars, sonographers, other interventional radiologists, very, very quickly how to recognise the lesions. So, if for a sonographer, they're often used to doing the ultrasound of the carotids, where already measuring intimal medial thickness. And it looks very similar. So for them, I kind of say, if you think of a carotid, you think of the echo grey band that's the inside within the lumen of the carotid and what you measure, and think of a fistula in that way. And they all immediately go, oh, okay, yeah, I can see the intimal thickening. When I teach registrars and other consultant colleagues, I generally show a few pictures and then we'll look at a few patients together. So they usually join me for an ultrasound list. And by the end of the list, they're confident at identifying, intimal thickening on ultrasound. I think teaching someone to do a good standard at ultrasound in vascular access takes a little bit longer. And I've taught some of my nephrology colleagues as well how to assess AV access and ultrasound, and recognise the interplasia, I think, is the easiest part of it.
So when you see this intimal thickening, is this hyperplasia of cells regenerating that would probably make them better for treatment with DCBs, or it may be also lots of fibrosis within this intima thickening, which perhaps in that case, DCBs might not be so helpful. Do you have any ideas, any papers about this subject?
So we did we published a pilot paper, sort of a pilot study, looking at a small number of lesions where we examined the lesion on ultrasound, and then when the patient went for surgery, collected the specimen, which was kind of standard practice in our institution, and examined it under histology. In those small number of lesions, we did see small hyperplasia, and we saw some where there was fibrosis. Our histologist stained them with an EEG stain, which looks for both. The fibrosis tends to be patchy in them, and predominantly lesions are intimal hyperplasia. We've just completed our collection, our writing up, and have presented as oral presentations the results of the AV sonoplasty study, where we did exactly the same thing but on a larger scale. So when a patient was coming for surgery for treatment of access dysfunction, we either rescanned the patient or looked at the scan that was done prior to surgery, and then collected the specimen, examined the specimen. We saw some lesions purely with hyperplasia, and some lesions combination of intimal hyperplasia and fibrosis. And again, where the fibrosis was seen, it tended to be kind of patchy fibrosis. And just drawing back that, what makes good angioplasty? I think we all know that when you treat the excess lesions, even the inflow lesions sometimes need high pressure balloon or a cutting balloon. And those seem to be those kind of more fibrotic lesions. But I mean, no, because no one would ever be able to do that study where you kind of balloon it and go, was that fibrosis or was it not? I have no idea. But, maybe they are. And then the other stage of a good angioplasty is perhaps the anti-proliferative treatment on it. But I don't think we're there yet as to every single lesion. And we've got more and more technology coming out. We've got the vessel flex, the flex to prep. And again, that should be really good for those lesions with fibrosis and perhaps preparing the vessel. Going back to the question of, what's the kind of the main lesion, I don't think we know, and we don't have any way of identifying fibrosis on ultrasound. But does it matter? Because if you see it, you're going to treat it and you're going to fully efface an appropriately sized balloon. And if you see the hyperplasia, it's hyperplasia. And we know that the intimal hyperplasia is a layer of, as you said, sort of cellular overgrowth or regeneration post-angioplasty. So does it really matter if there's a bit of fibrosis there? Does that affect what we're going to do? I don't think we know, probably not. But yeah, I think it's very exciting, isn't it? Well, I find it exciting being a bit of a nerd.
Do you have any idea if any locations like postanastomotic, cephalic arch, central lesions, which locations might be more susceptible of developing neointimal hyperplasia compared
Well,
to others?
the majority of the lesions that we studied were juxta-anastomotic lesions. That's certainly in my own practice where I do use sort of more DCBs and see more lesions with intimal hyperplasia. Having said that, For some of the poorly maturing fistulas with de novo lesions, you can also see lesions with no intimal hyperplasia. The area which I personally don't see a huge amount when I scan it, one is it can be quite difficult because it's deeper, it's the cephalic arch. Um, and there probably you've got different mechanisms of stenosis going on, as well as some of the other mechanisms that we see commonly. But the cannulation segment is another segment where we often see intimal hyperplasia and thickened vein. But cannulation segment can be quite difficult to treat effectively, purely because it's the cannulation segment, and often you have to ask and speak to the vascular access nurses about moving the puncture sites afterwards. Sometimes that's not possible because it's only a short segment of vein. I certainly see the different areas and anatomical areas of AV fistulas do seem to behave differently, don't they? I mean, the cephalic arch, for example, basilic vein swing points, higher rupture rates, they're often really stenotic, use a high pressure balloon. Maybe they respond better to stent grafts. We don't know. The JA segment, personally, have a very high threshold for using any stent graft there, even if it ruptures. But that's one place that I use probably more DCTs than I do in other areas of fistulas, and
So,
where we've slightly better data because we've collected more specimens from that area.
so you're not really using so much covered stents, are you? Because I think there is a tendency to use covered stents more and more. That's really
Yeah,
practice.
yeah, absolutely. There is, isn't there? I do use the more, where would I use them? Graft vein anastomosis, of course. Got good level 1 evidence for that. And I think they are very effective there. And grafts are, by their nature, kind of high risk. They can be a little bit more difficult to monitor clinically. Um, I use the predominantly covered stents. I use them in the cephalic arch, the central veins, and basilic vein swing points are the areas where I use most of the covered stents.
Basilic vein swing points as well?
Yeah, sometimes, but it depends on your surgeons too,
Mhm.
because it can be an area that's amenable to reintervention, and it's really important to have that discussion. As if we stent across here, have you got another option for a graft? Does it limit the patient's access options in the future? Um,
And Kate, what's the percentage of your procedure you're doing under only ultrasound, or are you using ultrasound combination with fluoro?
I generally use a combination of ultrasound and fluoro. If it's a really nice, simple lesion, single lesion, or even two lesions in, say coming out from the involving the cannulation segment or the venous outflow up to the cephalic arch, I'm quite happy to just purely use ultrasound. Used ultrasound for all the endo AVFs and also the repeat interventions on the AVFs. And, since using it, I used to kind of start using it more and more. I've always used it a lot, but I think after that's when I started using it generally to treat a lot more lesions. Where I've not used it so much, other than an adjunct, is and a really useful, important adjunct that, right, it cuts down your screening time, it cuts down your procedure time, so much is the JA segment, in particular of a radiocephalic fistula, because they can be a little bit fiddly. Um, but having said that, I had one the other day that I was prepping to treat from the distal radial artery, and then do it all under ultrasound. So I'm a big fan of using ultrasound, but it's difficult, isn't it? Because not everybody does. And one of the not barriers I have, one of the interesting conversations I have is when a fellow comes with me or a senior trainee, and they're like, "Oh, no one else does it like that."
Yeah.
You know,
Well,
Um,
I can tell you that especially after I I did my endo AVFs and
Yeah.
ultrasound became more and more common in my practice. I, I, I basically do everything under ultrasound now, unless if it goes above the clavicle.
Yeah.
I don't even do fistulogram for final verification because
Yeah.
basically I do my ultrasound, I do my dilatations as long as it is, after the clavicle. And if I'm clinically happy afterwards, I don't see any reason to do anything else. And I almost never had any particular problems for me to do any fistulograms. And it's definitely easier to do ergonomically. It's better. You don't have to wear the lead. The personnel is more happy in the room to avoid using that. So for me, it has been transformative.
A good result as well, Alex. Do you agree? I
Yeah,
mean, I've done a fistulogram. I thought, oh, that looks okay. And then you put the ultrasound on and you're like, no, that's not great. Actually, I
totally
have
agree. Yeah,
enough luminal gain.
yeah,
There's maybe a little flap there that I can tack back with a prolonged balloon
yeah.
inflation.
The other thing is also, sometimes in some lesions that are very short, especially in a radiocephalic anastomosis,
Yeah.
that you may have overlapping of the fistula with the artery, uh, you're not going to be able to see this very well with the fistulogram, but under ultrasound, it's very, very obvious where it is. Another ultrasound also, you can uh, mobilize your sheath, have your sheath just barely inside the lumen, and then just play with it and just put the wire and balloon it all the way. So I don't think I don't only think it's equivalent, I think it's better than doing fistulogram. Of course, we should avoid, it's either this or the other. They are complementary, but I think it would be a big benefit for our colleagues to use ultrasound more and more for these procedures.
Yeah, I definitely agree.
Can you describe a bit the setting that you have that makes your endo AVF practice and overall access practice so successful? What is it that you're trying to create as a team?
I think it's creating really, really good fluid communication across the team. Often at the center of that is usually the vascular access nurse specialist. And having IR play an active role in that. Um, what we have kind of what you see, what we have at Brighton that we also had in Stevenage is a really responsive team rather than just a purely reactive team. So there'll be a program that involves a degree of clinical surveillance. So measuring volume flow with dialysis, measuring venous pressures, the whole look, listen, and feel from the nursing staff being having a nurse kind of who leads that conversation, making sure that people examine the access on a regular basis, talk to the patients. If there's a problem, then that will trigger. Usually, dyspraxic ultrasound is the first investigation of choice, or if it's something really urgent, then there are same day clinics to see the patients. And then having access same day to an IR opinion or vascular surgical opinion, and then getting prompt and timely treatment for those urgent problems, and having a DT on a weekly or fortnightly basis that functions to discuss the patients with the less urgent problems, but where we need to make a decision about the access. Do we carry on with the access? What's the cause of the dysfunction? What's the treatment? What are the treatment options? It sounds really, really simple, really, really boring, but those things work. And then once you have the really, really simple, really, really boring things, then you can push that to do the more exciting things like the endo AVF once you've got that relationship. Because it's key with the endo AVF. I always said that kind of the least important part of it was the actual procedure itself, although it's very important. The most important part of it was making sure that the patient was suitable, not only suitable anatomically, but also suitable in that they were keen to have the endo AVF as an option. And then after performing the procedure, having somewhere that you follow the patient up and working collaboratively with the vascular access nurse specialist was key to that. So we initially started scanning the patients together at 4 weeks. And after a while, we stopped scanning together. And our vascular access nurse specialist, Ryan at Stevenage, was absolutely fantastic. So he knew what parameters made a successful endo-AVF. So he could measure the volume flow and the volume flow in the veins and assess it for any dysfunction. And my kind of tip from him was, I now know what they can puncture. So where the endo-AVF needs to be, where I can mark for a cannulation segment. So once you've got that kind of team working, and then if there's a problem and you need to talk to one of the surgeons about flow diversion, then you've got that conversation going. And Ryan could identify any problems or issues and say, look, this patient I think needs to come straight for intervention. I've scanned them. I'm happy that there's an issue with perforator. And, you build up your surface like that. So it becomes very responsive.
So it's the vascular access nurse specialist, the interventional radiologist, the access surgeon.
Yeah, and the nephrologist obviously is key for the referrals. Our nephrologists were, they liked the endo AVF because we were quite responsive. We could get the patient in quite quickly and timely to do their treatment, whereas sometimes in some centres there can be a long wait for surgery. The other aspect was the patients were very satisfied with them, the patients that we did, because I think we chose them well. They were primarily patients who wanted an AVF for cosmetic reasons, and that was a slow growth in the in the patient population because they see the endo AVF, right? Because someone else has got one. I say, oh, I like so-and-so's endo AVF fistula a bit more than I like the other fistula, so I'd like one like that, please. So there's those young patients in particular for cosmetic reasons. For those patients where they had had a previous experience of steel, we did a number of patients and they had no steel with the endo AVFs that we made. Those patients who had heart failure, and we didn't want to create a high flow fistula. And we did have some patients who had some outflow fistula issues with the cephalic vein, where we had the multi-flow fistula and on the dual punctures cephalic vein to basilic vein. That was, really, really good option for them because they weren't suitable for a BCF, right? Because they have huge problems with it. So it really fit with the treatment algorithm. And once you've done something, it's been successful, then you see your referral base grow and grow and grow because the surgeon and the nephrologist would see the patient in the access clinic and start having that conversation about, is this one for an endo AVF, and then refer on.
Were you able to take the horse or horses with you in Brighton?
Oh, yeah. And Dizzy. So she's joined me down in Brighton and she is loving life by the sea. I'm really lucky. She was in an excellent yard and I've managed to find another really, really excellent yard. So we're out competing and enjoying each other's company and having great fun when I'm not with the family or at work.
Kate, I'm very, very happy for you. You deserve only the best, and your patients are very lucky to have you and taking care of them. And I really want to thank you, and I really appreciate that you took the time Friday, end of the day, end of the week, to have a chat with me about these issues that we both care about so much. Thank you very much, Kate.
Oh, thank you so much, Alex. Always a pleasure to chat to you.